Thank you, Darek. So let me call the next chairman, who will be the past president also of our club, Alfredo Ruggero Galassi and George Sianos, will be joined on the web by Goran Olivekrona, and we go to what everybody expects, live cases, live examples. There will be a parallel session, so who is still a little bit willing to learn the basics of CTO recanalization can go to the second floor, the green room, where we will have a session together with GISE called ABC of CTO recanalization.
Thank you, Carlo. Thank you, everybody. And it's a great pleasure for me to be here. After 15 years, we started, and still we are here. And also live. And I saw before George was coming here. With George Sianos, you know that we started European experience in retrograde revascularization. And really a great pleasure now that retrograde revascularization CTO is basically a standard procedure among all of us, among all CTO expert operators, and the results of the club also for among the younger fellows, which are now called members, who are candidates to become associate, who are candidates to become members, are growing significantly. So I think Goran Olivekrona should be arriving soon, and we are now glad to start also the live cases, and we are thinking we are connected with the live cases. George, you would let's add something?
Well, I would like to also to welcome everyone. It's a great pleasure to be here today and sharing this session with Freddy Galassi. I think it's the cases that we're going to see today coming from China. It's the progress of the connections of the club with other continents, and on that respect, I think it's expanding. It's a field that it is expanding, and people are getting more interconnected, and we're very pleased to be able to collaborate with other societies in our main meeting. I would like also to invite the discussants, Sinista Ostojic, the Michael Pieper, Dr. Pixarasis is here, and Satoru Sumitri and Dr. Dimitriadis from Mainz, and Dr. Michael Banes. Please join us. Hello, Goran.
I think that Dr. Stylianos Pixaras will be connected by web, and all the others are pleased to interact with the live cases, which I should be very, very excited. Goran here is on the web as well. We can see you live on the web, on the monitor. And so we are basically now ready to start, I assume. Hello, nice to meet you.
Hello, good morning. Welcome to the Guangdong Provincial People Last Day of China. Yeah, I'm Dr. Luo, and thank you very much for the class and the panels. We are so great, great honor to be here to share with one case. And can you hear that?
Yes, yes, now it's much better, thank you. So
right.
Go ahead with the presentation of the case.
Sure. Could you show me the presentation? The slide, please. One. So next one. Today the case is 58 years old gentleman. He has a recurrent chest for more than 10 months and has some risk factor for the hypertension, diabetes, something on. And also he had a quite good renal function, and the ECG is good. The echo shows his quite normal ejection fraction, and maybe 2 or 3 weeks ago, we just fixed his LAD and OM, because at that time we found the patient have a 2 CTO and with triple vessel disease also. Next one, please. Next slide.
Prossima diapositiva.
Okay. Here's angio, right after the angioplasty before, and we can see the right coronary going to be the
one minute, we cannot see your images. 1 second. Okay, now we can see. Go ahead.
You can see that?
Yes.
Yeah. You can see that the target vessel today is right coronary and a long CTO lesion. Next one, please. We cannot see the stump. Not clear. Next one, please.
Prossima diapositiva. Okay.
And from the LAD, you can see a number of the branch supply the distal RCA, something like a PDA. So it's quite attractive, something like a first one, second one, and third one. We also can see actually there's another CTO located in the circumflex. The mid-distal circumflex is totally occluded already. Next one, please. So we also put patient for the CT scan. Here we can see the CT show is he had quite a big coronary, and then have a quite heavy calcification. You can see located all the CT body. So based on the algorithm from the maybe from the American, maybe from the Europe, probably we have to the strategy for this long RCA lesion. So is there any suggestion for this one?
Well, definitely there are a lot of good collaterals, straight collaterals, big channels, CC2, so I think that probably you could have very good chance to go retrograde. We understand that the antegrade approach is very, very difficult in this case. Although from CT scan we realize that antegrade there is not much calcium and retrograde there is a lot of calcium. So this is also changing CT scan our approach. Nowadays we are used to use CT scan a lot and probably to change sometime our strategies. What do you think, George?
Actually, this is a very good example. It shows a lot of information beyond what we got from angiography, because we can see the extent of calcification, the extent, of course, of the occlusion we see the huge remodeling of the vessel. One thing that we really underestimate in the CTOs is how big the remodeled vessels are. This right coronary, if it is 5 millimeters in its ostium, it becomes a vessel of 1 centimeter in the body of the occlusion with extent of calcification. So the information gets there, shows how, what they're calling the base operations, how big space it is, and that's why you see these huge knuckles and we're still in the vessel architecture. So I believe that this image shows a lot of information about how to handle the case. It shows a case of JCTO score 5, that it will not be able to be solved by any means antegrade or purely retrograde or whatever. So this is a case that will implement the full force of all techniques and materials.
Okay, so any other comments? Go ahead, show us also the live angiography. I like the angiography.
Okay.
Yeah, so we can have a better idea.
So today we just finished the angiogram for here. Can you see that? 把这个造影传过去。
We are seeing now CT scan, only CT scan.
Okay.
Okay, this is the global algorithm now.
Okay. 把那个造影。
造影。
Okay, now angiography, please.
信号切到造影，不要换灯。
Okay.
Okay, thank
now
you.
You can see, right?
Now we can see. Okay.
Right. So from this angiogram, you can see the one stent located the proximal LAD, and that's the bilateral angiogram. Still can see a long CTO lesion located in the RCA. So next one, side port, okay. Yeah, you can see the collateral channel is quite attractive, right?
Yeah, that's correct. You have multiple connections, although the only caveat here is that they're big vessels, but they're quite tortuous, I might say.
Yeah, right. It's very attractive. Actually, when we are waiting for the live, we already finished some work already. So, so after this angiogram, any comment or suggestion for the case?
We are not seeing live cases, live images now, please. We are looking at the previous slides. Can we see live cases, live angio?
Yes.
Okay, now we can see live
Now
angio.
you can see, right?
Yes, okay. So tell us what did you do?
So we are thinking about this long lesion. The proximal cap is not so clear. So initially, we have to prepare for the retrograde approach. But it's no doubt we can use the antegrade preparation. And according to the CT scan, we hopefully all the calcification is located in vessel wall, not in the vessel. Not in, hopefully, something like a ISR CTO.
Okay, go ahead with our your retrograde strategy.
That's the next one. Okay, strategy is okay, the globe. So here we begin use the M+1 7 French for the antegrade. That's the APT Microcatheter.
Do you have bifemoral or biradial?
No, there is one femoral.
One radial, one femoral.
Okay. And the right is femoral?
Okay. Yeah.
The right is femoral.
Okay.
No, the right is radial. Radial.
Radial.
The right is radial. Okay.
Yeah.
Okay.
Yes.
Okay.
So you
It's
have
also 7 French.
which catheters do you have antegradely?
Antegrade we use M+1.0,
Okay.
7 French. The left side going to be 7 French, EBU 3.75 from femoral.
Okay.
Here's a retrograde. We just use the microcatheter from APT, and that's a cyan wire.
So your attempt antegradely was with the microcatheter and which wire antegradely?
Antegradely is going to be XDA, right?
XDA.
Okay.
Actually,
very soft wire.
And then
at
you
the very
stopped.
first we
And
passed
then you
them.
stopped, basically. Okay. Is it correct?
Yes, because
Okay.
of very long lesion.
Okay. Okay. Now you change to retrograde approach. Okay.
Okay. Tip injection we can see very clear is almost straightforward with small curve.
So which wire is that?
I think that's not difficult. We can go.
Which wire crossed the collateral?
Sure 03.
So free. Okay. So very soft wire. That's a T injection. It looks like something like a taper stem with a distal cap, maybe.
I think this is an injection, just to clarify, because we see some contrast that goes around. If you see before the cracks, there was a subtotal occlusion. And I think the catheter is in this lesion, and then when you give contrast, essentially, you don't see any perforation there, but it's a kind of a super blush for the people not to be afraid of this picture. So the contrast that comes from the microcatheter is in a wedge position. That's why you see this kind of contrast going around. But it is not any perforation, just for the clarification.
All right, thank
also,
you.
similar to our previous case, we are really care about this bifurcation, distal bifurcation. So retrograde approach in a way may be more safe, or at least more reassuring us that we are getting the two branches free of dissections.
So what's going to be your strategy? It's going to be very interesting, Freddy and Senishan. This is about to see not only that, but to see what's going to be the reaction in different continents.
Yes.
Because although we do have global algorithm
now we have global
on
algorithm,
paper,
so
but I don't know if our mental status is in the same plane.
so we are getting more confused than before.
Yeah. So please go ahead.
I think also it's nice to begin integrated always, and almost all of the cases, and it's the same procedure or the same situation like the last one. We have a complex and very calcified distal cap, also as you mentioned with subtotal occlusion directly distal to the distal cap. So to go again a retrograde is a big advance. I think it's the only solution actually to gain the procedure.
Yeah, you're absolutely right in this case, because I do believe that in this specific anatomy, any kind of an ADR procedure, even re-entry that based on the lesion proximal to the bifurcation, it would be not unrealistic, but it will make the procedure really cumbersome. If you say that we don't want to use retrograde, yes. Because ADR even by wires or by device, in this specific case, it would have been problematic.
I would like to say to the audience that we are starting with George retrograde CTO revascularization course in 2011. Now it's 10 years, and we stopped then not because we thought that it was not important to go retrogradely, but because everybody was using retrogradely and all meetings were using retrograde. So our course repeated in 2011, 2012, 2015, 2017 in Switzerland, then of course was not of any use anymore, because retrograde approach now is basically used by 95% of operators. I would say 100% of operators. So this was the reason why we stopped this course, and now we are using retrograde revascularization.
I would put it in a different way. It became an artificial separation.
Yes.
That the retrograde is something different.
Yes,
Today,
it is part of
all of the techniques, antegrade, ADR or RDR or whatever, it's part of an armamentarium, that it is all a continuum, that it has to be respected, and that's what it's all about.
Yeah, it's part of the strategy.
Strategy. So please tell us, what are you doing there? Exactly. What are your thoughts? Because we're chit-chatting here to fill in the gap. So what is your strategy? You can keep on working.
Hearing that. Yes. So next step, we use the XTA to try that. So it's not a good sign for that. It looks like the wire should be inside the vessel architecture, but we are not quite sure. So in this point, we just start the anti-grade wire. So in this point, I want to ask you guys, you want to use knuckle wire technique in this point?
We're coming to the initial comment that to go in a kind of a wire escalation technique here in such a long lesion, it wouldn't be easy without all that intra-occlusion calcification. So it also a little bit depends on, you can try a kind of a Gaia wire retrograde to see whether it can make a very good progress within the occlusion, but it's obvious that you need a stiffer wire than XT. And if it doesn't make any quick progress that will lead you close to the proximal cap, then you have to do knuckle retrograde or antegrade. So I think intra-occlusion knuckling should be necessary in this case, unless with a short Gaia 3 or Gaia 2 you can make big progress retrograde. Because antegrade, I don't think so that you will do.
Yeah, I agree, especially looking at the multi-slide 16 and looking at the length of the occlusion. That definitely probably we have to marry the approach, United States approach, to go more with polymeric wire, stiff polymeric wire retrogradely, and try to dissect, and probably trying to just tackling the proximal cap to re-enter by direct reverse cut, otherwise to dissect up to the ostium. From the web, Joran Oliver Kron has some suggestion, and please go ahead with your strategy. Jianfang.
Thank you, Freddie. Yes. And a very nice case from China. I think the strategy is good to go retrograde. I would be concerned with the calcification down there. I hope it's not circular calcification where you can get stuck with your microcatheter. And I think often you end up in a need for a knuckle wire here to sometimes go outside of the calcium in order to bypass the circular calcification.
Thanks,
The great
Joran.
job
So
they're doing.
Jianfang, tell us what you did, because for the sake of time, we would like to see the end of the procedure. Please go ahead.
Okay. Yes, actually, we switch the wire to UV-free and then try to approaching CTO body. And in this point, why we didn't use the knuckle wire? Because you can see the microcatheter channel is not so good and cannot push in anymore. At this point, if you want to do the knuckle wire technique, probably the microcatheter cannot go, not enough support. So I just thinking about using more stiff wire. Right here, we change
Which one?
UV-free.
Which one?
UV-free. UV-free
Okay.
Okay.
from Asahi.
I think it's a very good choice because we know that tapered wires, like GISE, they do have some issues
Not
with
the taper wire.
calcification.
Yeah, actually. Yeah.
Yeah.
It's not so stiff. It's intermediate stiff wire. And then also we use the UV-free for the anti-gray also. So why we do that instead of the knuckle wire I just mentioned? And in this point, probably we can figure out where is the vessel architecture, because I have a lot of calcium can guide us to approaching the wire. So the most difficulty is in this point. You can see two wires are a little bit separate,
Yes.
but it's dancing together.
This is a very important point. Sometimes reverse cart may change position within the CTO segment, and you need to go more with antegrade wiring instead of continuing to push in the retrograde wire. I think it is a very important message. To move the place of re-entry may help you to get the two wires together in the same plane of interaction.
The previous image was very encouraging, especially in this one, but in the other projection, the wires are looking quite far. In this projection, I think the wires are not in the same plane. And that's exactly what we're talking about. Because you can fight with the occlusion for 5 hours. That was the old Japanese style. You remember the meetings that we were doing, and Osamu Kato was doing all these 5 hours procedures, wonderful procedures that we were seeing. But today the answer is that do we want to stay 5 hours in a case or not? And I think the case is that we don't. And Freddy Galassi said before something that it is important. We do have evidence that they don't do worse when you have ADR stenting, subintimal space stenting, especially when it is located within the occlusive part. So anyway, you're showing a great resilience there of making it right. And we're coming again back to the point that if it was US, the knuckle would have gone 3 hours ago. If it was Europe, it would have gone an hour and a half ago.
Yes.
In China and Japan, still we're persisting
You are right.
on the super correctness.
We don't know how long is spent to do this, because this is all recorded. So we need to know how long you spent to do that.
Actually, for this, about half hour, less than half hour.
Okay.
Because when we're waiting,
great.
you're just watching your whole section and learn something and then work.
Great
so,
result.
Standing behind me, Dr. Yang, he's young but very senior operator. So he did all things. All right.
Great.
Well, that is
right now is we can feel much better, right?
Yes.
Yeah, absolutely. There is one
So
overlap.
basically, you are not doing a reverse cart. You are just trying to realign the two wires by each other's, right?
Actually, in this point, we try to do the reverse cart, RDR.
Okay.
Okay.
Small balloon.
What we did, we used the guide extension from the APT Expressman and the 5 French guide extension and the 2.0 balloon. And all the way down. And
may I ask you something? What kind of microcatheter you have, Retrograde? What kind
Retrograde right now is from the APT, the microcatheter.
Sorry, I didn't hear that.
APT 1.9, 1.9, 1.9 French.
Microcatheter.
Say
So
the,
actually,
say please tell us the name again.
Okay, that's a Chinese homemade microcatheter from APT.
What?
APT.
Company is APT.
What's the name of it?
APT. Yeah, APT
Okay.
China. We don't know
APT.
that.
I don't know that microcatheter. Okay.
Okay.
All right.
It's good.
So maybe the first show in Europe. And actually, we can see the retrograde side. We can see guide extension That extension is 3.2 French.
Yes, this is
It's
a very important point that guide
retrograde
extension
support.
nowadays are very well used and very frequently used. This is very, especially in places where you have a lot of money, you can use it. You can also abbreviate, you shorten your procedures a lot. Of course, it's a lot of issue regarding the cost, but this is a very important point. Guide extension is a very important.
So, what balloon do you use there to make the perforation of the to make the 2.5?
2.0.
2.0.
2.0. Okay, small balloon.
That's also the benefit.
Yes,
when
yes.
you align the wires very well.
Yes.
Then you
to
need
use
small
a small
balloons.
balloon profile and then making direct reverse cart, and then by the guide extension be able to re-enter as Jianfang is showing us. Okay, so
Wonderful.
basically now the procedure is done, and please go ahead quickly.
But let me say that
Okay.
CT scan
Actually, I think it's
helped a
not
lot
done. We
because-
just use balloon. And right now, please take a look at the IVUS, please. IVUS. From the IVUS, we can see a lot of severe calcification. Maybe
转到 IVUS 了吗？
like a ring on the vessel wall. You can see the IVUS?
Yes, we can.
Yes, yes, yes. Thank you.
Okay, sure. That's the imaging right after the 2.0 balloon for the whole segment. And then we use the iLab iris and take a look at the whole vessel. You can see.
Yes. Also, sometimes it's interesting looking with the IVUS that sometimes your wire is getting inside, outside the true lumen in sequential mode, and really very often during the path of the CTO. And this makes the issue of making the connection distal and proximal very important as well, because sometimes you think that you are in true lumen, you shorten your length of the stents, and then you are having distal part
The guide
not
extension.
covered. Yes.
Then we will pull back the guide
So
extension.
right now, the issue is, are you going to use the rotablator for this case?
I don't
Or
know.
just go ahead balloon?
I don't think so. CT scan showed basically that there was no much, well, even HIVUS is showing us that there is not much circular calcium. I don't know, what is the idea from the panel? I would start with standard balloon and then see how does he behave, and then probably, depending on the result of the balloon, trying to...
But there is already a distance from the calcium which is 2 millimeters. How can you ablate that? The only real solution here is that you have to do balloon dilatations, and if the calcium is not cracked well, and with the position, then you have to go for IVL.
So only
I don't
balloon...
believe that it's such a big vessel rotablation has, or the classical rotablation, except if we had the other atherectomy,
the orbital, indeed.
orbital.
Also, for such cases with big vessels, no option with
so you have an
rotablation.
eccentric, and then you create bigger lumen. But I do believe that in this case, you should just go on with balloon dilatations and see what kind of result you will have.
Sure, sure, sure. So
3.0 的高压。
in this point, we're going to use the balloon. Yeah, and go ahead, finish the whole case. All right, thank you so much.
Thank you very much. Thank you.
2.5 和
It's a
3.0 的
great
高压。
demonstration. We will come back to you for the final result. Should we go to Amsterdam
to Milan.
to see
Yes,
how the
Milan is
performance
ready,
evolves?
so try to take your time to do reconstruction and with stand by stands, and then we shift to Milano. Andiamo.
All right, thank you. Yeah, we just finished the stenting. So
Okay.
Dr. Yang going to show you the final, maybe.
Okay. Give me a minute. I'll show you the course. We just follow the panel list. We dilate with the non-compliant balloon, 2.5, go to up to 26 atmosphere, followed by a 3.0 non-compliant. Then we check the IVUS. Okay, can you see the IVUS? 倒数对最后的 IVUS.
Okay.
Was that elevation in
I
EKG
was
present at the
switch
beginning?
to IVUS. Okay. Okay, the IVUS there.
Very distal, a big nectarine, but calcium neck, it's open up. Right here,
Okay. So,
it's break. Calcium is break.
Spotty.
Okay.
All right, good. Go back to the.
Okay, back to the angio, please. 回到造影，
回到造影. Okay.
回到造影。
Yeah, we back to the.
Yeah, and I use the IVUS catheter the sensor to precise position my distal landing zone over there. Next, we pick up the longest 3/0 stent. It's a 3/0 by 36 or something, yeah. We dilate, deliver with the 16 atmosphere, then connect with the 3/5 by 38, then 4/0 by 14. And this is the result.
Okay.
After this, we are going to do some post-dilatation with the 3/5.
Yes. Can you show us also the epicranial to see the bifurcation more clearly?
Okay, sure.
Okay.
Application, take a look.
Yes.
It was interesting that the ostial stenting was done with a wire into the... It's one version of the technique, just to have a marker of where you put the proximal marker.
Definitely, we need to have an over non-compliant balloon to expand better the stents. Show us the bifurcation.
Yes, I'll show you.
And we have to close the session.
After this.
Wonderful.
Okay, wonderful
Very
case.
nice. Excellent.
Thank you. Thank you very much, sir. Thank you.
I think it was a
And
fantastic session.
this is my tutor, Dr. Luo, Professor Luo here.
Okay, thanks a lot.
And my buddy Hong Chuliang and Zhang Yuansheng. Thank you, guys.
Thank you very much. Thanks a lot.
Thank you.